Hi, my name is Shauna Coe. I'm the Director of Nursing for Aspire Home Health, and I'm over the home care. I want to go through what I call mini orientation today to get you acquainted with some of the basic parts and educate you to what we do on the home care side and touch just a little bit on hospice. But I want to just share with you our mission and vision. And when you come aboard to Aspire, you're going to get one of these great little cards that you can carry in your purse or in your jacket or your Aspire jacket, and just remember what Aspire's vision is. I do want to say the one thing about being with Aspire is I'm always able to tell new employees that Aspire will always do the right thing for the right reason. That makes me feel very comfortable about our care and being an employee here. Our Aspire vision is aspire to be a positive influence on humanity. And our Aspire mission is stated as providing compassionate, quality care in the Aspire way through creating a personal experience that empowers those we serve to reach their goals and achieve their highest possible quality of life. We'll go on now to some of the home care components. First of all, infection prevention and control within the organization. This is very important on the home care side, well, even on the hospice side, as we track and trend infections as they are identified in our patient population. This is something that we have an infection control log. We follow the state regulations in everything we do. We also identify any infection that comes as we care for the patient, what I call under our watch. If it be a urinary tract infection or a respiratory infection, pneumonia, a wound infection, all of these must be tracked and trended. I tell new employees as we think about nurses, let's say I'm the nurse out in the field and I have 3 catheter patients and I'm sent out to do a catheter visit, and all of a sudden those 3 patients that I serve have urinary tract infections. That kind of alerts me on the trending that maybe as a manager, I need to make sure that we have correct technique and that we are specific in doing sterile technique, and maybe we just need to do a refresher and education course with that clinician to make sure our care is always 100% standard best practice. The next thing that we do is our quality assessment performance improvement process. This is so important to an agency, and we're required to do, the short form of that is called QAPI, Quality Assessment Performance Improvement. I like to tell new employees that performance improvement starts with them. It starts with us as an employee to see if there's anything that we can identify in our performance that would make our care better. We want to always provide the most excellent care to our patients. And please look around when you're here at our agency. If you see something that we can improve in, we welcome that. We want to make sure our processes and our care are excellent so that we can follow on our QAPI reporting and make sure that we're providing that great care. One of the things that we look at and make our determinations from are our scores, our HCAP scores and our claim-based measures, data that we collect on our OASIS tools. All of these things are important, and this might seem overwhelming today, but as you have more time with our agency, you'll see that these things are important and they make a difference in our outcomes, and we want good outcomes here. Our desire is to be a 5-star agency. So as a new employee here with us, you're going to be part of making this a 5-star agency. The next thing is confidentiality of organization and patient information, or as we all know it, HIPAA. HIPAA is very much alive and well, and we need to respect that. We need to protect patients' health information, and it's a huge thing. That kind of information being out there for the public to see is not acceptable. And huge fines can occur if we do not follow the governing rules for that. One thing to remember that I think is important is when you're using your device or sitting at a computer or even have some physical notes, paper notes, that you make sure that that information isn't available for anyone else's eyes. How HIPAA, I think I remember to make it appropriate is, remember, we can share information along the continuum of care, but it's not appropriate to go out to lunch with friends and tell about Mrs. Jones' visit today and all the things that happened and what's going on with her medical care. That would never be appropriate. And you know what? I found that this world is way too small. Just around the table at McDonald's is Mrs. Jones' husband, so please do not share information outside of the healthcare arena. Available community resources. Nurses think that they have to do everything, and that is not true. We are so lucky within our agency to have wonderful social workers, and they can be called into any home if we have those orders to provide care and additional resources to patients and families so that they can meet their needs. And that can be as simple as just helping with some family dynamics and who's going to care for grandma and who will rotate through shifts in the home. They might help give ideas for that, but they are wonderful at everything in the community, knowing possibly how to get Meals on Wheels, how to access senior care programs. Many different ways to help families. So we want to make sure that we remember to get an order for our social worker and allow them to come in and help with those community resources. The next thing is equipment management. This is, I smile when I read this because on the hospice side, this is something easy to accomplish, to provide equipment in a patient's home. Under Aspire, on the hospice benefit, equipment is all provided by Aspire and paid for by Aspire under the hospice benefit. But on the home care side, I always say you have to give away your firstborn child in order to get equipment or oxygen or any of those things your patient needs. So just know that equipment can be obtained for your patient, but one, we work through different insurances who may or may not give approval, and two, then we have to arrange with a DME company, a supply company, and make that happen. Partner those two together and try and meet the patient's needs, but it can be done. What makes that job, just on a side note, what makes that job so easy, if I can partner with the discharge planner at the skilled nursing facility or at the hospital to provide those things so that that can be handled and it arrives when the patient arrives home and there's not a challenge in trying to get that covered going forward. The next thing is home safety issues. This can be a challenge. We have so many diverse patients out in our community. We are getting referrals from so many places, and we deal in lots of different environments. So some of the safety issues would be, we might go into a home and it's a little bit of a hoarder home, or it's a lot of a hoarder home, and it's hard for the therapist to even create a pathway for that patient to walk. But on really critical safety issues, if you go into a home and you feel the patient cannot be cared for safely in that home, we do not admit that patient. You would call a supervisor, myself if I'm your director, or even the hospice nurse would want to call her director and talk about the situation. But on the home care side, we have had circumstances where we have had to try and place that patient back in a skilled facility where they could get a little more stable, where they would be safe to have the home care. As an example, we had a patient who was transferred home from the hospital. She had used her hospital days, and when she arrived home, her family was not available. She was unable to transfer out of bed. She couldn't transfer to the bathroom. And in essence, if you thought about not being able to get out of bed, she wouldn't have access to meals or getting to her medications. It was a situation that was not safe to accept for home care. So under that circumstance, I was contacted as director, and we were able to work with a local skilled nursing facility / rehab to get her back in, to get her a little bit better before coming home to try and tackle this alone. So there are many ways we can care for that patient and meet their needs, but we may have to adjust the plan of care for a little while. Okay, the next point is storage, handling, and access to supplies, medical gases, and drugs. So it's quite different on the home care and hospice side. We have access to numerous supplies, particularly many wound care supplies. So it's really nice when the nurse has wound care orders that she is able to come into the office, get supplies for her patient, and provide that care. As far as Medicare patients, I want to just clarify this a little bit. We'll probably have to state it several times as you get new assignments on Medicare or managed care patients. But for Medicare patients, we are required to provide all supplies. So for instance, if I have a patient that is a catheter patient and I'm just doing catheter care and that's what I have orders for, but my patient also has an ostomy, I am required to provide all those ostomy supplies until we discharge that patient from our service. If that patient tried to get ostomy supplies from their normal supplier, they would get a message back saying, it looks like you're on home care at this time. We cannot provide those supplies until you are discharged. That has happened to us a couple of different times until we kind of get in the process that we are completely paying and providing those supplies for those patients. As far as medical gases, that's referring to oxygen. And as I said earlier, getting oxygen for a home care patient does require the offering of your firstborn. It really is difficult. We have to have a face-to-face with the doctor, a doctor's order, and that they must fill out all the Medicare paperwork. So it takes jumping through a lot of hoops. So if that can happen at the facility, it's so much better. The other thing is with the oxygen and with our home care patients, different DME companies, different oxygen companies accept different insurances or the Medicare insurance. So we have to make sure that we connect the two, that we're using an insurance company that is a preferred provider for that patient, so there's no additional cost. We're always an advocate for the patient. As far as medications, the home care side and the hospice side are very different. Under the hospice side, all medications are covered if they are related to the hospice diagnosis. On the home care side, it's a very different story. All of our patients have numerous different pharmacies that they get their medications from. So doctors write orders, they call in the prescriptions to the pharmacies, and patients or families pick up their prescriptions. So as far as a nurse or the Aspire home care employee, we aren't picking up those meds or delivering those meds or providing the meds. However, it is our responsibility as a home care nurse to check those meds on our visits, make sure the patient has enough of each of their meds, and say when the blood pressure pill is low or another important med, that we alert the physician's office that that med needs to be reordered. Or work with the patient if they're capable of doing that and saying, did you see that your lisinopril is low today? Please let's reorder that while I'm here. So we want to make sure that we follow through our responsibilities there. The next thing is identification, handling, and disposal of hazardous or infectious materials. We need to just follow universal precautions on disposing of hazardous or infectious waste. That can be disposed of at a patient's home, but remember, we always are gloving when we're caring for those type of products, and we're double bagging. In the past, we used to put everything in red bags, but it came to a point where the red bag kind of signified or did a red flag to neighbors and friends who were wondering, what is all this garbage in this patient, in my neighbor's garbage? So we don't really do the red bag, but we do double bag and make sure things are properly disposed of. In our office, just so you know, we do have a disposal of infectious material as well, particularly sharps. So you can bring in your sharps container. If it's a sharps container from the patient's home, you can just double tape it, make sure it's secure so that anyone picking it up, like the garbage disposal people, would not be injured or hurt because of it. But we take care of it very carefully and follow those rules. Infection control practices in the home. Please follow universal precautions. We've had a good 2 years of learning how to wear protective equipment and making sure that we are protected and our families are protected by controlling that waste or protecting ourselves from exposure. So please don't shortcut that. Make sure that you follow those guidelines so when you go back home to your family, your spouse, your little ones, that you don't bring back into your home those infectious germs. Our next item is actions in unsafe situations. We have many different environments, and we serve all people, and we want to be able to provide care to anyone that we get a referral from. But occasionally, very rarely, there could be an unsafe situation. If you find yourself in that situation, please, if you need to step out of the home, and immediately call your supervisor, explain the situation, and we will take care of that and decide if we will be able to continue care in that circumstance. Other patient care and service responsibilities. I think what this means in the orientation and sharing with our new employees is that we have a service responsibility. We've committed to take this patient on our service, and we will do our best to provide the care that is ordered by the physician. The next thing is specific tests to be performed by hospital personnel versus home care personnel. For instance, we could have a UA order for a urinalysis, or maybe we're going to do a wound care culture, or we may be just doing a venipuncture for several blood tests for the physician. So what we need is just the order, and then of course we need an authorization for the visit, and then we would obtain those samples and take them to the lab. They would be returned to us through a fax, and then we would report the results back to the physician, who would then communicate with the patient what those results are. The next thing is advanced directives. Those are very, very different in the hospice versus the home care patients for this reason. In hospice, we know that oftentimes the patient may be declining and passing away quickly, and they need to address their advanced directives so we know their wishes and how to proceed as they decline and maybe not be able to answer for their care for themselves, and then eventually if they want to be DNR. For the home care side, oftentimes we're talking about maybe a 53-year-old male who just had total knee surgery, and he's planning on going golfing in 4 weeks. So they're very different circumstances, but both patients are offered advanced directives on admit, and they make that decision or that declination to give us an advanced directive or a DNR. With a DNR on both sides of the agency, we must have an order, and the DNR must be posted in the home to honor that DNR. The next section is appropriate policies and procedures. Of course, like any other agency, we have lots of policies and procedure books, and we will expect as your orientation progresses further that we will probably have you in front of those policies to browse through them to acquaint yourself with those policies. Why are they important? Because we are a Medicare certified agency. We follow state regulations, and when we are surveyed, we are expected to follow our policies. So it's important that you know what those are and what they mean to you as an employee of our agency. The next thing is screening for abuse and neglect. Unfortunately, it can happen in any patient situation. We hope it doesn't, but it is our moral obligation to report it if we suspect that there is any type of abuse going on with our patient in their home or environment. What would be the standard protocol is if you suspect that there is some abuse going on, you would report that to your supervisor. Then as a supervisor, what I can share what I usually do, I will ask and involve the social worker to go into that home and do a little investigation, visit with family and patient, or maybe just patient because it involves family. And then they can make a determination if that needs to be reported to a higher level. We are very open to reporting suspicious things that might be cause for harm to our patients to APS and let Adult Protective Services make that determination if anything else needs to be done. But it is your responsibility if you encounter that in one of your patients' home, to please report that to your supervisor. Guidelines for appropriate referrals, including timeliness. I love this little subject because I want to tell you a little bit about how referrals come to us. Referrals now, at this point, we have such a high Google review that we're getting referrals from everywhere and anywhere. Now, most commonly we get referrals from hospitals or skilled nursing facilities, rehabs, doctor's offices and clinics, but we also get numerous referrals from the community, from patients, patient loved ones, and from grandchildren, anybody who's associated with that patient who seems to need some help, and the family's reaching out to us for some assistance. With those referrals, they all must be backed by a physician's order. So sometimes it takes a little bit of jumping through hoops for us to get to the physician's office, get a visit note, or if that visit hasn't happened, ask the family to please get that patient to the doctor. We get the referral, we start to get it scheduled. Now, Aspire's policy is that we're going to try and admit in 24 hours. That kind of gives us a little bit of a gold star over many other agencies who are admitting in 48 hours. The state reg says that we will admit within 48 hours from receiving that order for admission. Now, does that ever change? Yes, of course. For instance, as an example, if a patient is coming out of a hospital and I get word that that patient will come out on 4/7 and I receive that order to admit, I would be admitting most tentatively on 4/8. But on the evening of, or the afternoon of 4/7, I get a call from the discharge planner at the hospital saying that the patient has developed a couple new symptoms and they're going to keep her a couple more days. Then that order somewhat becomes null and void, and they will send me a new order when she gets closer to discharge. So there's some circumstances that happens, or some orders we will have to call the physician and ask for a different order if admission is delayed. One of the things about the referral process and the timeliness in that category is for home care. I just need to let you know what home care does provide. We will get orders, and it can be for nursing, physical therapy, speech therapy, occupational therapy, home health aides, and social work. So there is a variety of services that can be provided, and so we get numerous referrals from lots of different sources with lots of different diagnoses that need to be cared for. The next thing is emergency preparedness within our organization and the home care setting. That's important, and also a condition of participation item. What we need to do is make sure when we admit the patient, the admit nurse will inquire of patient and family if they have an emergency preparedness plan, and that is documented on our OASIS. The other thing is we have emergency preparedness manager. It's our CFO. He is over emergency preparedness for our office, and we do follow the state drills during the year and document that, and he gives us updates at team meetings if we need emergency preparedness updates, and we have a plan in the office. If we ever had a disaster, there is a phone tree that we access and take care of our patients, because that is their right to have care and remain safe during any kind of disaster. So we make sure that the services they need, for instance, if they were on oxygen or a concentrator, that if the power went off, that we have a plan in place to take care of these people. Patient rights and responsibilities and ethical issues. Each patient, as they're admitted, they are given a book from Aspire, and it describes the rights and responsibilities. And in general, patients have a right to have good care. They have a right to be respected and treated fairly. They have a right that they have care, and it's not subject to race or religion or color or anything that would be discriminatory. So that is our promise to them and their right to have this care. The responsibilities that we want to make sure the patient is also aware of is there's two sides of that coin. And the patient should be responsible to tell us when they won't be home for a visit. Maybe they have a doctor's appointment, or that something has, they haven't been following their plan of care, which is very important. That is their responsibility as we give them direction that they follow that plan of care. So there are two sides of that, rights and responsibilities. And as you go further with your orientation, you'll learn a little bit more about those rights and responsibilities. The next thing is cultural diversity and sensitivity. And I think that that is so important on the home care and hospice side. But as we care, it's a very tender experience when you're caring for patients, and particularly for caring for the hospice patient. Their desires and wishes we need to be very sensitive to, and sometimes their cultural practices are very different, and we need to be aware of those things before it happens. So as you bond and spend time with your patient, it's really important that you get to know if they have any different practices. I'll share one quick little incident I had. I was called to do a patient that was on a GIP, general inpatient hospice care. I went over to provide that care and felt that I should not touch the patient at that moment and do his death visit, which would have been removing the IV and removing his catheter. Shortly, a gentleman came into the room and identified himself as the son. And he said, "Did you touch my father?" And I said, "No, I haven't completed my visit or even started it as yet." And he said, "Oh, I'm so good. My father is from Africa, and he has moved to the United States in the last 20 years, but he still goes by our old practices, and we cannot touch his body for 8 hours." That was such an awakening that day for me to realize that many different cultures and many different religions and many different people have special practices and requests, and we need to be aware of those. And it works both ways on the home care and the hospice side. Okay, this completes the orientation for focusing mostly on the home care with a little touch on the hospice, but I'd like to turn the rest of the orientation over to Mary Johnson, our hospice director.